Welcome back, everyone. Today, we're jumping right into a high-yield, step-by-step explainer. Think of this as your ultimate diagnostic masterclass for conquering the, let's be honest, often totally confusing world of intestinal protozoa and Trichomonas. You know that feeling when you're staring at a clinical vignette, just trying to differentiate between these microscopic invaders that all seem to cause the exact same symptoms? Yeah, we've all been there. So you're absolutely in the right place. We're going to decode the specific traps, the unique morphologies, and those crucial caveats that you literally have to know.
Okay, let's dive into this. We've got a 4-part syllabus today. Transmission traps, clinical clues, our diagnostic masterclass, and finally, treatment tactics. Now this 4-step sequence, it isn't just a basic agenda for this explainer. It's actually the exact methodology you're going to use as a resident or a practitioner when you're evaluating these easily confused pathogens. By really sticking to this framework, transmission, presentation, diagnostics, and treatment, you're building this mental scaffolding. And that's exactly what lets you confidently deduce the right answer on any board exam and, more importantly, out there in the actual clinic.
All right, step 1, transmission traps. Let's look at how these pathogens actually spread.
Test makers and attending physicians absolutely love to trick you when it comes to how these bugs spread. So you really have to listen for those specific alarms hiding in the patient's history. Here's a classic scenario you're going to see time and time again. A patient develops watery, non-bloody diarrhea right after drinking mountain stream water on a camping trip. It sounds totally idyllic, right? At least until the gastrointestinal distress sets in. So which specific pathogen are we tracking down here?
The culprit is Giardia lamblia. And the trap here? It's all in the water treatment. See, Giardia cysts are completely resistant to routine chlorination. So, if your vignette mentions that water purification tablets totally failed, immediately think Giardia. You actually have to boil or physically filter the water to kill this thing. And honestly, what's even more terrifying is just how efficient it is. The infectious dose? It can be as few as 10 individual cysts. That's practically nothing.
And this brilliantly illustrates just how vastly different protozoa can be when it comes to spreading. Just look at this contrast. On one hand, you've got Cyclospora. This one notoriously hides on things like imported raspberries, sweet peas, and basil. And get this, its oocysts aren't even immediately infectious when they're passed. They actually require maturation out in the environment first. Then on the other hand, you have Trichomonas vaginalis. Now this is virtually always a sexually transmitted infection. It has absolutely zero cyst stage, none. It's just actively motile trophozoites getting passed directly from person to person.
Moving on to step 2, clinical clues. This is all about spotting the symptoms.
Okay, now that we've figured out how they get in, let's rapid-fire some of these high-yield clinical traps. For Giardia, definitely watch out for sulfurous belching, along with a really distinct lack of fever or blood in the stool. Next up, Cystoisospora. If you ever see a protozoal enteric infection paired with eosinophilia, ring the alarm. That is a completely unique feature among enteric protozoa. And for Trichomonas, the trap often lies with the male partner. He usually acts as an asymptomatic reservoir, while women typically present with a malodorous yellow vaginal discharge, vulvar erythema, and itching. Now, a patient's immune status can completely change the clinical picture here. In Cryptosporidium, it's the perfect example of this. In an immunocompetent patient, it really just causes a self-limited watery diarrhea that hangs around for a week or two. But if you're looking at an AIDS patient, specifically someone with a CD4 count under 100, it completely transforms. It becomes this devastating, chronic, profuse watery diarrhea. It can even cause biliary involvement, which ends up mimicking conditions like sclerosing cholangitis.
Just to put the severity of Cryptosporidium in AIDS patients into perspective, let me show you a number: 25. That's up to 25 liters. That is the sheer volume of watery diarrhea this infection can cause per day in severe, uncontrolled cases. Think about that. That is an absolutely staggering amount of fluid loss, which obviously leads to really rapid wasting.
Let's look at another classic clinical vignette. Say you have an AIDS patient presenting not just with chronic diarrhea, but they also have sinusitis and, quite specifically, keratoconjunctivitis, inflammation of the eye. Chronic diarrhea plus eye and sinus issues, that is a highly specific combination.
And the answer to that vignette is Microsporidia. Specifically, we're talking about the E. helem strain. Microsporidia are these tiny, opportunistic, intracellular spore-forming protozoa. And here's the distinction to remember. While the E. biennii strain mostly just causes diarrhea, E. helem specifically disseminates. That's what causes that signature keratoconjunctivitis and respiratory disease.
All right, step 3, the diagnostic masterclass.
This is where we actually find the bugs. So we've covered transmission and symptoms. Now we're entering the real heart of this explainer. When you're prepping for the boards or just trying to confirm a clinical suspicion, morphology is absolute gold. Now, what's really interesting about this is how visually distinct these pathogens are under the microscope. Giardia is totally classic. Pear-shaped trophozoids, 4 pairs of flagella, and a ventral sucking disc. And that disc, that's exactly how it physically attaches to your proximal small bowel. Cystoisis spora, on the other hand, features these massive oocysts. We're talking around 25 micrometers, with 2 sporeblasts inside. And microsporidia? They are incredibly tiny gram-positive spores. Honestly, they're sometimes so small you literally need an electron microscope just to get a definitive tissue diagnosis.
Okay, let me sound another major trop alarm for you here. If you're reading a case or reviewing a lab report and the phrase UV autofluorescence pops up, your brain should immediately lock on to Cyclospora k10ensis. These spherical oocysts literally glow under fluorescent UV light. It's a highly tested, super unique diagnostic feature. Don't forget it. So let me challenge you with a really highly tested, real-world scenario. Imagine your patient has chronic watery diarrhea. You go ahead and order a routine stool ova and parasite, an O&P test, and it comes back completely negative. But the patient is still very sick. What must you specifically pick up the phone and request from the lab? Any guesses?
You absolutely must request a modified acid-fast stain. This is absolutely crucial. See, neither Cryptosporidium nor Cyclospora are reliably detected by a standard stool O&P. If you don't specifically ask the lab to run a modified acid-fast stain or maybe an antigen test like EIA, you're going to completely miss the diagnosis. And worse, your patient is going to continue to suffer.
And that brings us to our final step, Step 4, treatment tactics. Let's talk about curing the infection. Well, we've found the bug, so now we actually have to kill it. And listen, this isn't just about memorizing a list of drug names. It's really about navigating these tricky clinical caveats where giving the quote-unquote standard drug might actually do nothing at all. Here's a classic pharmacological trick for you. Nitazoxanide? It's a great drug for Cryptosporidium, but only if the patient is immunocompetent. If you have an AIDS patient with cryptosporidiosis, nitazoxanide is simply not going to work. For those patients, the actual treatment for the parasite is to improve their underlying immune system. You do that by initiating or optimizing their antiretroviral therapy, or ART. Immune reconstitution is really the only reliable way to clear it out.
So, the crucial point here is that nuances matter immensely in your treatment plans. For Cystoispora and Cyclospora, your go-to is going to be TMP-SMX. For Microsporidia, though, it gets a bit complicated. Albendazole works beautifully for the E. intestinalis strain, but there's basically no effective therapy for the EBNUC strain. If the infection is in the eye, you use topical fumagillin. And for Trichomonas, this is huge. If you only treat the symptomatic patient, you've failed. You absolutely must treat both partners simultaneously to prevent this ping-pong effect of constant reinfection.
Let's move on and see how this all builds into our clinical protocols today. Why do we stress treating both partners so heavily? Well, because we're finally catching more of these infections. Historically, we relied on a wet mount to diagnose Trichomonas, but honestly, that's only about 50 to 60% sensitive. You're practically flipping a coin. Today, nucleic acid amplification testing, or NAAT, has rightfully become the first-line, most sensitive diagnostic tool we have. It finally allows us to find those asymptomatic reservoirs and properly treat both partners. So, we've covered the traps, the clues, the morphology, and the treatments. But before we wrap up, I want to leave you with this final thought. In a world full of incredibly advanced medicine, why do our smallest, most ancient microscopic invaders still require us to specifically ask the lab to look for them? It's because technology only really works when it's guided by a sharp, highly trained clinician. And you know what? You now have the framework to be exactly that. Stay vigilant, keep asking those right questions, and use this masterclass to totally conquer your exams and protect your patients. Thanks for joining me on this explainer, and I'll catch you next time.